He's come up a couple of hours ago and he's had an arterial line put in, and actually his PO2 is 7 on 60% venturi.
Okay.
I had wondered about putting him to some high flow. I don't know how you feel about that.
No, I don't think there's any point in doing it to high flow. I think because we're worried about COVID-19 here,
Yeah.
I wouldn't use NIV either,
Yeah.
unless there's anything else in your assessment. Actually, before we even go in, I think we should prepare for intubation.
Okay.
Okay.
Yeah, we'll
Let's
get
go and
into
do
it.
that. Okay. So the key points in terms of intubating a patient with COVID-19 are preparing prior to entering the room. We've put our full PPE on, and we've used the ICU action card prior to going into the room. By going through the COVID-19 intubation checklist, we have all our equipment set up to go into the room. So we don't have to go outside the room to get any further equipment. We do need any further equipment. We've got our runner who can bring it in. The additional equipment that you might not always use, that includes having the closed suction ready to go inside the room and also having tube clamps available. The key thing is that the intubation should be done by the most senior person available. It should be first attempt, best attempt. So that may be things like early use of video laryngoscopy. Once the tube is down, the key thing is to inflate the cuff and minimise the amount of bagging that may be required, because that can produce a droplet spread and aerosolization. We'll now go into the room and show you how we perform the intubation itself. Yeah, so we've gone through the COVID checklist again now that we've been in the room and we're ready to go. John, we're just going to change your oxygen mask if that's okay. Oxygen down, mask away, and oxygen on. So guys, I've got my C circuit, I've got my HME, my end-tidal CO2 is connected, and we've got oxygen here. It's at 15 litres, and we're just allowing John to breathe that oxygen, and we're monitoring his stats. I'm going to do that for a full 5 minutes. Once we've done that for a full 5 minutes, Jilly, I'm happy for you to start giving drugs. So John, just going to feel a wee bit sleepy here, and Julie, can you do crack work, please? Can we go in the rocks there?
Natural rocking.
Okay, we'll start down the clock. 1 minute, we have 1 minute. We're monitoring saturations. We're going to try and avoid bagging if at all possible. If we see any desaturation, we're going to slightly increase the peak. The sat seems stable at the moment. Okay. That's been 1 minute. I'm now going to have a look with the video laryngoscope. Breezy, please. Got a great one view.
Okay.
Shoot, please.
I've got Bridget.
Tube is in. Breezy out, please.
Okay.
Cuff up, please.
Up.
We're reconnecting the C circuit and we're bagging the patient now. That seems good. We've got 1, 2, 3, 4, 5, end-tidal CO2, crack it off please. Okay, the saturations are stable now. Okay, so we're going to prepare to go onto the ventilator. So the ventilator is in pause mode. Can we reconnect the end-tidal CO2 on the ventilator tubing to the monitor please?
That's that new CO2 on the ventilator connected.
Okay. The ventilator is on pause. Can we apply the tube clamps, please? Tube clamp on. Oxygen off. Ventilator on. Tube clamps off. And ventilator on. Okay. That's grand. Thanks very much, everyone. Let's now get on and secure that tube.
So now that the patient has been safely intubated, we're going to doff our gear using a spotter to check that we're not inadvertently contaminating ourselves.